right, guys, we're going to walk through a case presentation today to get you ready for the boards. This is a very high yield subject that we're going to go over today. So let's start with a case presentation of some things you may see, how it presents on the boards, and then we're going to walk through the pathogenesis, important lab values, and everything you need to know to get it right on the exam. So we've got a 9-year-old male who presents with fatigue, vomiting, and difficulties arousing. Mom reports he's got polyuria, polydipsia, fruity breath, and developing deep, rapid breathing. On physical exam, he has altered mental status and appears dehydrated. These are his associated labs. So we're going to walk through what this patient's presenting with and then the high yield clinical information you need to know for the boards and to rock your rotations next year. So anybody know what this patient's got? He's got diabetes. Specifically, based on his lab results and his clinical presentation, he's presenting in DKA. So with his age, I would be most concerned with type 1 diabetes, but type 1 diabetes will often lead to DKA. We're going to walk through all that presentation and what that looks like. But what I really want you to know is what causes type 1 diabetes. So type 1 diabetes is due to no insulin. You have a lack of insulin production because you have a destruction of the pancreatic cells, specifically the beta cells, or you'll have the islet cells of Langerhans, make sure you know that. And what you get is you have some type of autoimmune destruction of these specific pancreas cells. And what you'll see is you'll see that white blood cells or leukocyte infiltrate of these beta cells. It's usually a T cell immune mediated process where you have autoimmune destruction of these pancreas cells. What that leads to is a lack of insulin, which can lead to type 1 diabetes and ultimately DKA, which is what we see this patient present with today. Let's just get down and break down the basics of diabetic ketoacidosis. Okay, first off, diabetic. Guess what? What do you think glucose is going to do in a diabetic ketoacidosis? Glucose is going to be high, okay? So, typically when you see labs, and you're looking, if I'm diagnosing someone with diabetic ketoacidosis, you're going to see very high glucose numbers, okay? So remember, you can do a bedside glucose, you can get the glucose off the BMP, but you're going to see high glucose, diabetic, all right? Keto means breakdown of what? Breakdown of fats, okay? So let's go in a little bit more depth on that. What is deficient in type 1 diabetes? Okay, remember, deficiency of type 1 diabetes is due to insulin, no insulin production, okay? So insulin, remember, its job is to help glucose enter into the cell. And how does it do that? Insulin will come to the cell wall membrane, all right, insulin, and it will trigger a whole cascade of factors to then produce GLUT4, okay? Remember, GLUT4 will then go to the cell wall membrane, embed itself, and then allow glucose to pass in, okay? So in type 1 diabetes, you have the lack of that insulin triggering the GLUT4 to go to the cell wall membrane to allow glucose in. So since glucose can't get in the cell, where does the glucose go? It's circulating all around the cell. So when you test your labs, what do you see? You're seeing that high glucose number right there. So the body, if it can't use glucose for the cell, what it's then going to do is start to break down fat. Okay, so remember, diabetic ketoacidosis, we have high glucose because it can't get into the cell. With the keto part, what you're doing is breaking down fats for energy. So oftentimes, insulin will make you stop gluconeogenesis and fat breakdown. Okay, so insulin turns off these factors. Well, since we have a lack of insulin in our type 1 diabetes, you then have to go to gluconeogenesis, which is the buildup of glucose in the liver. So allowing that glucose to come out of the liver and give you your glucose in the cell for a short period of time. And then once we run out of that gluconeogenesis, those stores in the liver, we go to fat breakdown. So you start breaking down fats, you're going to get a release of ketones. Also, that's why we see the acidosis. Remember, when you break down fat, one of the byproducts that you're going to see is acid product buildup, okay? So diabetic ketoacidosis is a buildup of glucose due to our lack of insulin production that causes then for the breakdown of fats. So in our labs, this is what we see with our lab values. Again, we talked about the glucose being high, okay? So that's what you're going to see either on a bedside glucose, so putting in the clinical part of it, get a bedside glucose or your BMP, okay? Basic metabolic panel. You're going to see high glucose. So what do we see also, how do we measure the ketones and the acidosis? So glad you asked. Because where you see ketones is where? Urine. Okay? So oftentimes with a patient you think could be presenting with diabetic ketoacidosis, you want to get a UA, all right? And that's going to measure for ketones. Honestly, too, the UA can look for glucose, all right? So UA, big deal. We love our UAs. Anytime you don't know the answer on rounds next year and you're like, what test should we do? Just say UA, because it's probably right, okay? Because that UAs are simple, they're cheap, and they give you a ton of information. So we can see ketone production in our UA, and we can also see glucose in that as well. So we see diabetic ketoacidosis. So how do we measure acidosis? So the other way that we can look at acidosis is think pH, all right? So your normal pH level is what? About 7.35 to 7.45. What are you going to see your pH doing in an acidosis state? Go up or go down? Going down, okay? So typically, in order to meet the criteria for diabetic ketoacidosis, you see less than a pH of 7.3. Okay, again, that is all from those breakdown of fats that you're going to see this reflection in the pH. One of the other lab values that you can look at, and one of the criteria factors you look at for diagnosis of DKA, is also in your BMP. Anybody remember what that one is? Your BMP is going to give you bicarb. Okay, and you're thinking right now, what in the world is bicarb? What are you going through that? So bicarb, remember, is a negatively charged ion. So what happens is bicarb is going to go and do its job of helping with all this hydrogen production from the fats, from the acidosis, is going to go and block that positively charged, that acidosis causing molecule. So your bicarb actually ends up going down because it's being used. So you'll see a bicarb usually less than 15, normal's about 22 to 28. I know my handwriting is phenomenal, but normally you see around 22 to 28. Closer in the diabetic ketoacidosis is less than 15. Again, because bicarb, being a negatively charged ion, is going over to combat your positively charged hydrogen or acidosis that's going in over there, okay? So again, breaking down DKA, diabetic, high glucose numbers, ketoacidosis, due to the breakdown of fats, you're going to see ketones and you're going to see acidosis, okay? So, comes to the point, how do you treat it? Well, go back to what the source of your type 1 diabetes. Now remember, typically DKA is seen in type 1 diabetics. Type 2 diabetics, you can see sometimes DKA. Normally you see HHS. That's another video for another time. But for this one, you're going to see due to no insulin, what do you think we're going to give them? You're right. We're going to give them insulin, okay? So give them all that good insulin that they can do to help push, again, the glucose into the cell, okay? So insulin is your go-to for treatment. Now, one of the side effects that you can see when you have insulin is it's pushing in that glucose. What's something else that insulin will do? It can push in potassium, okay? So sometimes you'll see some potassium, the hydrogen-potassium exchange that happens at the cell level. You can see some issues with the potassium. You usually see it in DKA, we'll see a pseudo-hypokalemia, which is because of that potassium going into the cell. When you add the insulin in there, you'll see that exchange kind of transform from there. So that is why outside of insulin, you give a ton of fluids, okay? So in DKA management, And oftentimes these fluids are laced with a ton of electrolytes, again, because of these different electrolyte channels at the cell. That's all due from the insulin abnormalities, the glucose changes. You'll need to give a lot of fluids as well with your insulin to help base that out. So, last thing we're going to go through, what are some ways that diabetic ketoacidosis patients are going to present to you? So, this is really high relevant for the boards. The majority of times, and you guys know I love this, that you're going to see DKA present for the very first time in pediatric patients. And this is the first sign that they may have diabetes. Because what are some things that you're going to see DKA patients or diabetic patients in general present with? They're going to present with increased urination. They're going to present with a lot of thirst because of that increased urination. They're going to present with maybe some nausea, vomiting, increased fatigue. And one of the things as they progress, as we're not treating, as this gets worse, this process gets worse and worse, as you're going to see those symptoms get worse and worse. So you're going to see worsening nausea, vomiting, that fatigue that can set. One of the things that you're going to see boards really high is called Kussmaul breathing, okay? So what does that increased breathing pattern look like? Well, again, how does the breathing, the respiratory system affect this right here? You can breathe off that excessive hydrogen ion, all those positive ions, by increasing that respiratory drive. So one of the things that you'll see is this deep breathing pattern that's going, those are called Kussmaul breathing. You may also note that their breath smells a little bit fruity. Where's that coming from? Ketones. Ketones will give that fruity kind of burn off or that fruity odor that will come from their breathing pattern. The other thing we'll see is that Kussmaul breathing because they're getting rid of those hydrogen ions, all right? So again, you know the pathogenesis of that you're going to see with diabetic ketoacidosis, what lab values and how to interpret those, and then you want to see how with their treatment. Again, insulin, fluids, and then monitoring the respiratory status. This is all going to fix those electrolyte abnormalities that you're seeing. And then again, the main part, because they have no insulin, you're going to see that you need to replace their insulin to allow that glucose to get in the cell. So, quick recap. Again, big patient populations you're going to see on the boards is pediatric patients presenting for the first time. We don't know they have diabetes, but for the first time they're going to present in diabetic ketoacidosis. And then any patient, think of like a teenager or a young adult who is not taking their medications, or older patients who may not be able to, who have type 1 diabetes, who are not able to afford insulin. These are question stems of how they're going to set you up for a patient presenting with DKA for the first time. Let me know if you have any questions. That's DKA in a quick snippet.